Okay, good afternoon, everyone, and welcome to the Ultrasound and the COVID-19 Beast. This is an EMSSA webinar. So my name is Dr. Vidya Lalu, and I am the Pretoria representative of the EMSSA Ultrasound Special Interest Group, or the SIG, as we like to call it, the Ultrasound SIG. And I'm going to be the host for today. With me, I've got our expert panel, and that includes Prof. Mike Wells, Dr. Craig Beringer, and Dr. Sean Gerety. And we are all emergency physicians, but behind the scenes, we've got another emergency physician who you've seen now, Dr. Jed Hart, that work with the IT and logistics. Let me introduce you to the panel. Prof. Mike Wells is an emergency physician, ultrasound extraordinaire. He is also our very own president of EMSSA, the Emergency Medicine Society of South Africa. Thanks, Mike. I have asked each one of them to give us a little bit of insight into what, just so that the rest of you can get to know the panel a little bit better. So Prof. Mike Wells says that the pandemic has reinforced to him ultrasound is indispensable for emergency medicine. He thinks that it's pandemic, where many of our other tools like the stethoscope are problematic to use. Dr. Craig Beringer.
I didn't catch that.
Sorry,
could you try again?
Dr. Craig Beringer is the current chairman of the Ultrasound SIG. He's also an emergency physician with a long-standing interest in ultrasound and particularly in lung ultrasound. The pandemic has turned Craig into a homeschooling dad, and it has uncovered some special talent that he has for cutting children's hair. Dr. Sean Gerety found a special interest group, and the pandemic has got Sean thinking very deeply about mental health of herself and of those around her. It's got her noticing how we respond to times of stress. She's been figuring out how to learn, how to rest, how to look out for one another, and also what resilience and restoration looks like in the midst of an ongoing emergency. So the ultrasound and the COVID-19 beast, I'm sure you are all intrigued, and rightfully so. I don't think it's going too far. I'm going to let the cat out of the bag and tell you all that all of us on the Ultrasound SIG are pretty much obsessed with ultrasound. And so by calling the ultrasound the beauty, that's not too far-fetched for us. And of course, as we face this beast, the COVID-19 pandemic, we turn to our ultrasound, our beauty, to provide answers for us. So we will be covering the following topics. Craig is going to be talking about lung ultrasound in COVID-19. Then Prof. Wells will be covering echo for COVID-19. And then Sean will take us through both the airway ultrasound for endotracheal tube depth and conformation, as well as infection control with ultrasound. But before we jump in, I want to remind you that this is an interactive webinar. So if you have any questions or comments, please type them into the chat. You will get a chance at the end, either at the end of each person's session, if time permits, or else at the end of the webinar in total, where we will read the questions or comments on the chat. We will then give you a chance to unmute. You can also choose to turn your video on, and you can then get an opportunity to ask your question. While Craig is going to put up his slides, I also want to remind you that this webinar is going to be recorded. It's being recorded, and the link will be available on YouTube, so it will be quite publicly available. And with that said, just keep your mics off, and let Craig take it away with lung ultrasound in COVID-19. Thank you, Craig.
Thank you, Vidya. Thanks for the introduction, and thank you for all the organizing to get this webinar together. It's much appreciated. So when we met as the EMSSA Point of Care Ultrasound Special Interest Group at the start of this pandemic, we were all in agreement that we needed to put out a webinar highlighting the role that PoCUS can play in COVID-19 disease. One of the main focuses of our SIG is to continually strive to promote the appropriate use of PoCUS in all clinical spheres, and with the overall goal of improved patient care. So we certainly hope to achieve this through this webinar, is completely free and open access, and a recording will be made readily available to all those interested at the end. As with everything surrounding COVID at the moment, there's a general paucity of good quality evidence, and the role and utility of lung ultrasound is no exception. So much of what we're doing with lung ultrasound and COVID has been extrapolated from the existing lung ultrasound data on pneumonia and viral pneumonias in particular. So just an overview of what I'm going to go through. So firstly, I'm just going to cover the why you should be performing lung ultrasound in emergency department for suspected or confirmed COVID pneumonias. Secondly, the when. So what are the recognized indications for lung ultrasound in COVID? And just as importantly, when you should not be performing lung ultrasound. Thirdly, we will look at the how. So covering the basics on how to perform lung ultrasound in general, and then some specifics related to COVID. And then finally, we'll finish up with the what. So this will include a brief overview of the general lung ultrasound artifacts and findings, as well as those findings that are relatively specific for COVID. I've intentionally left this until the end because if you don't know why you're performing lung ultrasound and what the correct indications and technique is, you shouldn't be interpreting any images that you generate. It will lead to more confusion than help, ultimately to the detriment of your patients. So let's get on to the why. So why should you be performing lung ultrasound on suspected COVID or confirmed patients? Firstly, lung ultrasound is probably one of the easiest PoCUS applications to master. There is lots of evidence to show that individuals can learn the skill and interpret images accurately with minimal training in a very short space of time, something which we all know is lacking in a pandemic. The lung surface area is large, so literally just putting on a probe on the patient's chest, 99% of the time you will generate some form of image that you require. All you guys that are experiencing to get views, get your echo views, lung ultrasound is completely the opposite. The other real benefit of lung ultrasound is that it's rapid. It's a quick exam. Because the images are easy to obtain and they're relatively easy to interpret, it makes it a very rapid bedside test. It takes a maximum of 5 minutes to complete, and that's for a comprehensive lung ultrasound exam. And because you're the clinician performing the exam, you've examined the patient and taken history, the results that you generate, you can act on immediately based on your findings. There's no waiting for printing of X-ray films or uploading of images or radiology report. You can act immediately. So not only is it easy and quick, it's also accurate. There's good evidence to show that lung ultrasound outperforms chest X-ray for the diagnosis of all forms of chest pathology, from pleural effusions, pneumothoraces, and pneumonias, with equivalent sensitivities and specificities to CT. And it appears that this is no exception for COVID pneumonias. Even the limited data that we have at the moment. It can lead to significant cost reductions. So when used appropriately, lung ultrasound reduces the need for chest X-ray and in some instances CT. It has also been shown to reduce ED length of stay as well as hospital length of stay. So obviously, along with the reduction in the number of chest X-rays and CT scans, comes an obvious reduction in radiation exposure for each patient. On average, a patient in ICU receives a minimum of 5 chest X-rays, depending on their length of ICU stay. So obviously, with lung ultrasound, this can be drastically reduced. So after providing you with all the significant benefits of lung ultrasound, I suppose the answer to the question, why perform lung ultrasound in COVID, would be, why not? But it's important to note that no procedure is free of risk. Particularly now in the setting of COVID-19, the risks are extremely high with regards to infecting self, staff, and other patients. So if you are going to perform lung ultrasound, make sure it will have potential benefits such as changing treatment management and patient disposition. So I always talk about this concept of engaging brain before using your ultrasound machine. Be the brain at the end of the probe, that you've taken a history and examined your patient and you're interpreting those images in the context of your patient and using it appropriately. If not, it can potentially lead to harm. So lung ultrasound can be performed at all steps in the workup and evaluation of COVID-19 patients regarding the when. One of the identified areas in which lung ultrasound can play a role is even before the patient enters the emergency department in the triage or screening tent. The Italians have been utilizing portable handheld devices to determine patients' disposition from the triage area. Symptoms and meeting case definitions of a PUI, had a brief lung ultrasound exam in the triage tent, along with standard triage vitals and a brief comorbidity history. So, and if they had normal vitals and particularly normal O2 sats and a normal lung ultrasound exam, they could then self-isolate. On the other hand, if they had lung ultrasound findings, it would assist with determining what area the patient was sent to. So a patient with significant lung ultrasound findings was generally sent to a monitored high care area, whilst those with minor changes were sent to more general ED areas. It's important to note that lung ultrasound findings were not the sole reason to base the triage decision on. Vital signs, particularly SATs, as well as patient comorbidities, informed their overall triage decision. This is an example, as you can see, from the Intensive Care Society in the United Kingdom. And just note how they combined a patient history along with oxygen saturations and lung ultrasound findings to ultimately inform their decision where the patient was disposed of. This is another screening tool developed by the team at the Nepean Hospital in New South Wales, Australia. And they developed what we refer to as the CLUE protocol, so COVID lung ultrasound in the emergency department. And basically they developed and used a developed score, the lung ultrasound score, and combined that together with the patient's oxygen saturations to determine the overall disposition, once again, of the patient. It is important to note that although there are several such screening tools utilizing lung ultrasound, none have been formally validated. We also know that there's no ideal diagnostic test for COVID. Even the current gold standard of isolating viral RNA with real-time PCR testing of respiratory tract samples is only 70% sensitive. And as such, even myself as the biggest proponent for lung ultrasound has to concede that lung ultrasound certainly is not the magic bullet when it comes to diagnosing COVID that we're all looking for. From the limited data we have though, lung ultrasound has a far better sensitivity and specificity than chest X-ray and has equivalent diagnostic accuracy to CT. The problem is that while it is a relatively sensitive test, lung ultrasound imaging does not equate to a diagnosis, a definitive diagnosis of COVID, and because there's no universally accepted pathognomic lung ultrasound findings for COVID-19. So its specificity remains relatively low. The lung ultrasound findings that we do see are suggestive of a viral pneumonia. And as we are in our influenza season currently, this needs to be taken into consideration. One well-recognized area for lung ultrasound is to monitor patients' disease progression. And because of ultrasound's portability, its rapidity, and ease of use, one can make rapid decisions at the bedside based on the patient's condition. A correlation has been found between worsening lung ultrasound findings and the need for more advanced oxygen therapy, such as high-flow nasal cannulae or more invasive forms of ventilation. Lung ultrasound can also be used to assist as a guide to management options. So it can play a role in lung recruitment, adjusting the amount of PEEP, can help guide proning patients, can guide ventilation modes or techniques, and can also assist with spontaneous breathing trials and assessing readiness for extubation. So now that we know why and when we should be performing lung ultrasound in COVID, let's go through how to actually do it. As mentioned before, this is key. You need to know how to perform a lung ultrasound properly before attempting to interpret and make patient management decisions on them. So which probe? You can image the lung with almost any probe, probably not the endocavitatory probe, but in general, any probe can be used. The general recommendation is to utilize the curvilinear low frequency probe. The low frequency is of benefit because it allows for deep penetration so that one can analyze the presence of B lines as well as pleural effusions. It also has a large footprint, so large areas of lung can be scanned, making your ultrasound exam rather quick. The phased array cardiac probe, one of these, can also be utilized, providing similar image quality as the curvilinear probe. And it also has the benefit of being able to image the heart at the same time, which would form part of a complete PoCUS assessment in an unwell COVID patient. The linear probe, because of its high frequency, is good for visualizing the pleura in more detail, but that's really about it. And as such, most of the lung experts generally dissuade from using a linear probe. So what I would suggest is to pick one probe and stick with it. You really want to avoid changing probes during your examination of a suspected or confirmed COVID patient. Obviously, you want to limit the time that you're there and limit the amount of probes that you need to then decontaminate and potentially spread bugs. Most of the modern day ultrasound machines that we use today are specifically programmed and designed to remove artifact. However, because lung ultrasound is different and we require the visualization of artifacts to make decisions about what's happening in the lung, we need to use this concept of dumbing the machine down. So often you need to ask your machine or your ultrasound rep or technologist to assist you with turning off specific feature effects in all their glory. Many machines have specific lung presets where this is already done for you to allow for this. If your machine doesn't have this, the abdominal setting is a good substitute for the most part. With regards to probe position, standard lung ultrasound convention requires scanning in the sagittal plane, so with the probe marker pointing cranially. So locate your area of interest and stop and analyze for a period of 1 respiratory cycle, so roughly about 5 seconds. So a full expiration and a full inspiration cycle. Avoid moving your probe during this time. You are trying to analyze a moving structure, in other words, the 2 layers of the pleura. So any added movement from your part will only make this more difficult. A key point is to ensure that the probe is 90 degrees to the chest wall and pleura. So your goal is to obtain cross sections of the ribs and intercostal spaces to evaluate the underlying lung. But be sure to stay perpendicular to the skin as shown in this diagram. Make sure even as you go laterally that your probe is still kept 90 degrees. This diagram highlights that. So can you see here, this is a very blurred, irregular, indistinct pleural line. And that's because the probe is not 90 degrees to the pleural layer. As soon as you adjust your probe slightly and ensure that it's 90 degrees, the bright white hypoechoic pleural layer becomes more visible. Many lung ultrasound exam approaches exist. So I would recommend performing a 12-point lung exam. So normally a 6-point lung ultrasound exam, which was described initially by Lichtenstein, and then the 8-point lung exam described by Valpicelli would suffice for most lung pathology. But if you look at the general disease distribution on CT scans from COVID, this is an example of a COVID-19 pneumonia on CT scan. It shows that these lesions are very patchy and may involve any part of the lung, but particularly the posterior zones. And these will be missed if you don't have a bit more comprehensive examination using a 12-point. So depending on the patient's condition and possible position, some areas may not be accessible to lung ultrasound. Just try to get as many points as you can to increase your sensitivity. So for the 12-zone approach, each hemithorax, as you can see, is divided into 6 zones. So an anterior zone, a lateral zone, and a posterior zone. And these are delineated by the anterior axillary line and the posterior axillary line. And then those areas are further then divided into superior and inferior regions. To further improve your test accuracy and not to miss any lesions, we describe a lawnmower approach generally as recommended. So that is to move through each lung zone, as shown in this picture, as if you were mowing the lawn, just ensuring you're not missing any surfaces of the lung while scanning. When it comes to positioning your patient, depending on the severity of the COVID pneumonia, a patient may be upright, they might be in a lateral decubitus position, they might be supine, or they might even be prone. So having the patient upright or in a lateral decubitus position will allow you to access all the lung zones. But unfortunately, most patients who have significant disease or are intubated may not tolerate these 2 positions. In this diagram, you can see this is the ideal, if the patient can sit up, this is how I would recommend scanning the patient from behind, such that the patient's airway is away from the actual scanner, and as a result, improves safety and reduces the risk of transmission. The most common position to scan the patient will be in the supine position, and the best way then is to have the patient's arm abducted. But just note that you will have more difficulty accessing the posterior lung fields if the patient can't sit up. And really, to get access to that subscapular area in supine patients, it's often helpful just to roll them slightly and then over to one side and using pillows and blankets to assist with that. You might also be in the position where your patient is prone, and you'll therefore obviously have difficulty accessing the anterior zones. And there is a technique which is called the swimmer position, described by Glade et al., to access the anterior thorax. And here what they do is just abduct the patient's arm and elevate the shoulder with the pillow, and you can get to those anterior zones of the lung so you can scan fully. So now let's finally move on to the what we're going to look for when we're scanning patients' lungs. This image here is the standard lung ultrasound image that should be obtained each time you're scanning every lung zone. So it consists of the 2 ribs with their associated rib shadows, and then the bright white pleural line which runs underneath and below those ribs. So that's what you want to get in every image. Make that standard. It's important to understand that lung ultrasound is different from any other type of ultrasound, as it requires and utilizes the concept of artifact analysis. The reason for this is that because lungs are generally filled with air for the most part, and air is a really poor acoustic medium for ultrasound waves, all the waves that are sent from the ultrasound probe hit the pleura and are reflected and scattered back. And as a result, we can't actually visualize the lung tissue itself unless it's a densely consolidated lung. As a result, we have to use what artifacts are generated from this pleural line to be able to give us an idea and understanding of what's actually happening in the lung. I like to use this ECG analogy. So just like in ECG, we're not actually visualizing the heart tissue, but instead we're using the electrical activity generated by the heart to give us an idea of what is going on. Exactly the same with lung ultrasound. We're using the artifacts generated from the pleural line to give us an understanding of what's happening in the lung. There are several artifacts described, and a lot of all the lung gurus have described nearly over 100 different types of artifacts, but all you really need to know to be able to master lung ultrasound is your ABCs, 3 basic lung artifacts. So starting with A-lines. A-lines are horizontal reverberation artifacts generated from the pleural line. So as you can see here, there's the pleural line and there's multiple A-lines that are generated. So they're just reverberation artifacts and they are equidistant from each other. And generally, when you're looking at A-lines and you're seeing A-lines, it means that it is an air-filled lung below your probe. Just looking at how they're generated. So when an ultrasound probe emits an ultrasound wave, it hits the pleura and gets reflected back. That continually happens. So this back and forth reflection of ultrasound waves between the probe and the pleura generates multiple equidistant A-lines, as you can see in the far field. And the reason for this is because an ultrasound probe and machine interprets time as distance. And that's why these A-lines appear much deeper in tissue. So here's a video of just demonstrating a video of A-lines with a normal aerated lung. So this is the pleural line, and there's the subsequent A-line artifact that is generated. And there'll be another one here, equidistant below that. The next artifact, the second artifact to recognize are those of B-lines. So they are the opposite. So they are vertical artifacts that arise from the pleural line. And there are certain key features of B-lines that you need to be able to understand and recognize. And the first thing is that they arise from the pleural line and they go all the way off the screen. And this is why it's important to make sure you are scanning at an adequate depth. So you need to ensure that a maximum depth of 15 centimeters to ensure that you can see them going all the way off the screen. They are bright white hypercoic lines. They are laser-like, and they move along with the pleura, obliterating the A-lines. When we're seeing B-lines, in general, it means that there is fluid within that lung tissue. So whether that be interstitial or alveolar. So this diagram shows how B-lines are actually generated. So this is the normal situation where you've got a normal interstitial syndrome, and as a result, everything gets reflected back and you don't visualize anything in the lung. Whereas if you have interstitial syndrome, whether there's fluid in the actual interlobular septal within the alveolar themselves, ultrasound waves can penetrate a little bit deeper into the lung tissue beyond the pleura, a little bit more scatter develops, and as a result, a B-line is generated. So this video is just demonstrating classic B-lines being generated. You can see that they're going all the way off the screen. They're moving as the patient breathes. They're sharp, well-defined, and going, and they're bright white. The last artifact is a C-line, and really of some relevance in a COVID pneumonia. And really what they are is a thick, irregular pleural line combined with a broad vertical hypercoic stripe, whether it is with an associated consolidation or not. And we'll have a look at those at some images later with COVID features. So moving on to then the typical lung ultrasound findings that have been described in COVID pneumonias. So the first is B-lines in all their various forms. So a whole variety of B-lines have been noted. The next key feature is that the pleural line is irregular and fragmented. And then associated small peripheral subpleural consolidations. So those are the three major findings. It's very uncommon for pleural effusions to occur. If they do, they are very small. And the most distribution of these findings typically tend to, in the early stages, occur in the posterior lower zones. And as the patient progresses in severity, it develops a more diffuse lung pattern similar to that of ARDS. So this diagram just describes as you can see that as the patient's condition deteriorates, you can see the lung ultrasound findings develop. So you're getting less and less lung aeration and more lung ultrasound findings progressing from an A profile to multiple B lines till they coalesce with subpleural consolidations and then to complete dense consolidations. Similarly, if the patient's improving, you can start to see these lung ultrasound findings changing. And this is why it's really good to monitor patients. You'll see that the B lines start to resolve and an A profile starts to dominate as the lung becomes more and more aerated. And the patient's clinical condition correlates with this. The B lines in COVID pneumonia are visualized in all their possible forms. And Volpicelli, who's one of the big lung gurus in Italy, describes COVID-19 pneumonia as a storm of B lines. So they are present in a variety of forms in a single patient. So there'll be areas of clearly distinct sharp B lines which are separate from each other. And then you've got progressing in other areas, you've got multifocal B lines, and then large areas of coalescent whiteout areas of complete combined B lines, sometimes giving the appearance of like a shining white lung. So these artifacts represent the typical signs of the disease, but they can also be observed in other interstitial diseases of various etiologies, and that's important to note. So can you see these B lines arising from the pleural line? They are single and distinct lesions and arising from that and moving with as the patient breathes. Here's another example of a COVID pneumonia, multiple multifocal little B lines arising from the pleural line and a typical feature of a COVID pneumonia. Another example of multiple B lines where they're starting to coalesce and join and start to form almost like a curtain type sign where they're complete joined B lines together. This is another typical feature of COVID pneumonia. So there are what these areas of we call skip lesions, and what you've got is an area of a completely normal lung. And then if you scan a little bit further lateral, what you start to see is an area of irregular pleura along with multiple B lines and suggestions of the pneumonia in that area. So areas of normal lung adjacent, you'll have areas of abnormal lung. If you want to have a look at this, this is showing what Volpicelli and his colleagues have described in one peculiar aspect of artifacts they've noted is invariably visualized in the very early phases of COVID-19 pneumonia. It is, however, unpublished data, but they're referring to a shining band artifact, which spreads down from a large portion of a normal-looking pleura, and then often disappears with an on-off effect as the patient breathes in and out. So the Chinese authors, so in a lot of the Chinese papers that were put out, they described it as a waterfall sign, but they didn't characterize it any further. So they described this was the coalescent B lines, and the top of the waterfall would be that pleural line. However, they didn't refer to it as a normal pleural line, or if it was normal or irregular. So Volpicelli and his colleagues went on to further describe it as a light beam effect. So just like a light beam turns on and off, that's exactly what they visualized as this beam artifact develops, as the patient breathes in and out. So in their opinion, they said the sign is demonstrative of a very acute phase of that ground glass appearance, which is typical of COVID pneumonia. So have a look here. This is a better example of it. So can you see this pleura is completely normal? And as the patient breathes in and out, you've got this shining artifact which goes all the way across, but it's on the background of normal lung tissue, so normal looking lung. But in and out, you've got this shining beam that appears to turn on and off. And they feel that this light beam artifact is very specific for COVID pneumonia. It's important to note that this is all anecdotal at this point, and it's all unpublished data, but it is something to maybe look out for in your patients. The other thing that we're going to just touch on are pleural irregularities that is typical of a COVID pneumonia. Can you see on this pleura, so say you were riding a bike on this pleural line, you can see that you have a very bumpy ride. It's completely irregular, completely fragmented, as opposed to this ride, much smoother, much more a normal pleural line, and that's what a standard pleural line should look like. Just another example of a very irregular looking pleura, and typical of a COVID pneumonia. And you can see how using a linear probe, the pleura becomes that more clear, and you can see that very irregular looking fragmented type pleura, which is once again typical of a COVID pneumonia. And then the last thing are your subpleural consolidations. And this is typically part of the C line that gets generated. So small areas of hypoechoic lesions just below the pleural line, generally less than a centimeter, and they are typical of a viral pneumonia. We do also see them in miliary TB, so that we need to be also aware of, but along with all the other findings suggestive of a viral pneumonia. So in conclusion, just to state that lung ultrasound in COVID is quick, it's easy to perform and interpret, and can have a direct impact on patient management, provided you use it in the appropriate context and realize that it's not the magic bullet for diagnosing COVID pneumonia. Cool, thank you guys, that's it.
Thank you, Craig. That was a very comprehensive understanding on lung ultrasound in COVID-19. So it really boils down to pleural irregularity and thickening, the B lines, and those areas of subpleural fluid collections or consolidations. That's amazing. I see there are no questions at this moment. Remember, guys, you can put your questions in the chat, but I will then ask Prof. Wells to share his screen. And while he does that, we know that COVID-19 is not only confined to the lungs. It has effects all over the body. It is, in fact, an endothelial disease. It affects the heart, the brain. It causes coagulopathy, cytokine surges, ending up in multi-organ failure, and so forth. So Prof. Mike Wells is going to educate us specifically about the cardiac complications of COVID-19 and how we may use our ultrasound to pick them up. Thank you, Mike.
Okay, can you hear me?
Loud and clear.
Fabulous. I have my screens are covered, which is adding a challenge. First of all, thank you. I'm not going to talk about how to scan, but I am going to talk about why to scan and some of the things that we can pick up using echo that can guide us in the treatment of COVID patients. I wonder if anyone recognizes the image that's on your screen at the moment. I'm sure you recognize the COVID virus or the coronavirus on the left. On the right is, if you're a fan of Overwatch, you'll know it's a character called Echo, and I guess that's appropriate for what we're about to talk about. So let's start by just looking at some of the things that can the COVID can cause problems with in terms of aspects of the cardiovascular system. Right, so we can get problems with arrhythmias. We know that COVID patients can get STEMIs. They can get STEMIs without any problems in the coronary arteries as well. One of the things that COVID can do is affect the compliance of the left ventricle, which will give us left ventricular diastolic dysfunction. We also know that, let me just bring that back. We can get problems with pericarditis, pericardial effusions. We can get pulmonary embolisms because of the increasing coagulability induced by COVID. We know that we can get combinations of pericarditis and myocarditis. And myocarditis can be bad enough that we can get substantial systolic dysfunction. Pericardial effusion can be as a result of systolic dysfunction, but also as a result of myopericarditis. And finally, and perhaps most interestingly, we can also get significant right ventricular dysfunction in COVID. Now, I'm not going to talk about all of these, but I picked a few that we can go through. will give us some indication of where echo is going to help us. And in no particular order, we're going to be looking at left ventricular diastolic dysfunction, which is a fairly advanced echo technique, but I thought it would be interesting to show you the current thinking in how we look at diastolic dysfunction. And for those of you who have some ultrasound and echo experience, this will be useful for you. We're going to look at pulmonary embolism, which of course is important in terms of how we might change our management of patients in the acute phase. We're going to look at severe systolic dysfunction as a result of COVID. And then we're going to look at right ventricular dysfunction, which is an important prognostic sign that we found. Now, it's clear that lung ultrasound is important because we know that sick patients, by far the most important organ is the lung. But in a recent study that was done in England, where they looked at data from nearly 70 countries across the world, they looked at 1,200 patients who were admitted. And they echoed these patients. And in 50% of the patients, they found that there was an abnormality found on echo. Now, traditionally, we regard echo as indicated if we strongly suspect underlying cardiovascular disease. But many of these patients were patients who had no history of cardiovascular disease as well. And perhaps even more importantly, they found that a third of the patients where they found an abnormality, there was a change in the acute treatment as well. So echo is really important. And I would advise that if you have a patient that you're thinking of admitting, a hypoxic or shocked patient, they're obvious. But if they're patients that just look sick, it's worth looking at as well, because we can get some good information from the echo. Okay, so let's look at some cases. This is a young guy. He's had some chest pain and breathlessness for a few days. He looks quite sick. He's shocked with a blood pressure of 80/50. He's COVID positive from a test a couple of days ago. The chest X-ray shows a big heart with some upper lobe venous diversion. It's got on the CT, it looks like COVID. And the ECG is quite worrying for a potential STEMI. So, of course, that's a patient where we would clearly want to do a cardiac ultrasound because it may show significant problems. And based on what the clinical scenario, there are a number of things that it could be. And then this is what we find. On the left, this is a parasternal long axis view that you can see, and on the right is an apical four-chamber view. And if you look at that, it's fairly easy to see that that left ventricle is not contracting as well as it might. You can see there are clear differences in the contractility in different areas of the heart, but you can just see that the overall squeeze of that left ventricle isn't good. And you can see that this is apparent in multiple different views. If you look at the apical four-chamber view, you can see that there's a good squeeze at the apex and the lateral wall, but the septum certainly is not doing very much. What's important to see as well is the right ventricle is actually a reasonably normal size, and in fact the right ventricle is contracting pretty well. We can see on both these images. So this would be most likely a patient with myocarditis, and it's quite important to treat these patients really well. What worsens myocarditis, obviously, is anything that's going to tax the oxygen supply to the myocardium. And one of the things that includes, of course, is hypotension. And so maybe counterintuitively, we have to start these patients on inotropes fairly early to ensure that the coronary perfusion is adequate. It's also really important to be very good with the fluid management with these patients. We know that COVID patients in general prefer to be dry. So we have to be fairly careful with our fluids, and obviously we have to balance that against renal function. And certainly we have to ensure that there's enough fluid to fill the heart, because the heart does need to be full when it's not pumping too well. And then we need to add the inotropes And here the most appropriate inotrope to start with would be something like butamine, which is reasonably cardioselective. It does produce some vasodilation, which should be beneficial. COVID patients can have hemodynamics similar to regular sepsis. In other words, they can be peripherally vasodilated already, in which case we might want to switch inotropic agents. But they're not always like that. And so, and unusually for sepsis, dobutamine may be a good choice here. So this is a reasonably easy echo finding, and with intermediate skills, you should be able to pick this up. And that will be enormously valuable, because to miss this and to keep pouring fluid into a patient who is hypotensive rather than inotropes would certainly aggravate the lung problems in a patient with COVID pneumonia. So that's our first scenario. And what we find with this guy, and these are all based on real cases, because the ECG changes, the patient had an angio, which was normal. And the treatment, this case actually came from the early days. So they were giving steroids then already, but different types to what we're advising now. And in fact, the patient improved fairly well, and over a number of weeks resolved well. And that's in the limited evidence of COVID so far, it is suggestive that these patients can do really well. Okay, so next case is an elderly lady with quite a long history of fever and now a recent onset of dyspnea. Her obs are reasonably normal, her troponins are up, she's got a positive COVID. Her CT shows, again, what looks like a COVID pneumonia, and she's got no DVT on the ultrasound and a reasonably normal looking ECG. So this could be pretty much anything. So let's have a look at the ultrasound. And this is the famous McConnell sign. This is an apical four-chamber view. What's centered on the screen there is the right ventricle. This is the right ventricle over here. This is the left ventricle. And what we're seeing is we're seeing a left ventricle that's contracting reasonably briskly. We're seeing very little movement on the right ventricular free wall, and we're seeing this little dipping in of the right ventricular free wall close to the septum. That's called McConnell's sign, and it's associated with two conditions. I'm sure you're all familiar with the first one, which is pulmonary embolism, and importantly, is hemodynamically significant pulmonary embolism. It's also associated with right ventricular infarct. It's important to remember that it can be either of those conditions. Now, what's important is in a patient like this, who we think has a COVID pneumonia, now suddenly we faced with these findings on echo, which suggest that there's a hemodynamically significant pulmonary embolus. And so obviously, instead of just managing this patient on oxygen and other therapies directed at the COVID pneumonia, we would have to actively and aggressively find out if the patient does in fact have a pulmonary embolism. The raised troponins at that really high level, again, that's not specific, that could still be right ventricular infarct or PE, but given the ultrasound picture, we would be quite concerned with a pulmonary embolism. So depending on if this patient was hemodynamically stable, certainly we would take them for a CTPA and then obviously treat them depending on what we find with this. D-dimer in the era of COVID is changed. We know that D-dimer is actually quite a good marker for severity of illness in COVID. So you may well have many COVID patients with high D-dimers who don't have PEs. But obviously, it's really hard to exclude PEs without then imaging such as CTPA. One of my concerns as well is that the Wells scoring system and the PoCUS scores may actually not be valid also in a patient with COVID. And so we're having to rethink completely how we assess pulmonary embolism in the ED. And certainly we're doing many more CTPAs than we were before. And we're picking up quite a lot of these patients with PEs as well. So this lady's acute PE, and remember they can present at any stage, and often they present with PEs with their COVID essentially as an associated finding. And we know how to treat these patients, thrombolyze them if they are truly massive, or anticoagulate them. And this patient unfortunately did poorly. Okay, so let's look at the next case. Is also an elderly lady. She got 7 days of fever and recent onset dyspnea. She's hypertensive, hypoxic. Her troponins are up, and she's COVID positive. Chest X-ray shows the non-specific changes that we've seen with all these patients now. ECG, we've got a big AVL and lateral T-wave inversion. And if that 14 millimeter AVL twin causes any memories, that's suggestive of left ventricular hypertrophy. One of the things also to remember is not everything is COVID. And sometimes we have patients with COVID who have other things that are actually causing the problems. And it's important to remember that. So what we would think of with a patient like this, and the typical patient is the elderly lady who's hypertensive, who's got heart failure, which is a diastolic heart failure. And we're going to go through a little presentation from 1, 2, 3 sonography, looking at the ways that we assess for diastolic dysfunction. This is an advanced skill. So it's really just to show you what it is. And for those who are interested, this is something that you could teach yourselves. For diastolic dysfunction, generally these days, we use a number of criteria, not just one, to diagnose diastolic dysfunction, as you'll see as we go along here. Okay, this is apic 4 chamber. We can see that there's a reasonably good ejection fraction, but the left atrium is big. This is now the transmitral flow. The E is bigger than the A, but there's the L wave, which is concerning for pathology. So this is one of the things that we can measure, the deceleration time. This is tissue Doppler imaging showing low velocities for the E prime, both medial and lateral, where they should be around about 10. And so if we've got 3 different criteria, then we know that diastolic dysfunction is present. Okay, so that was really quick, but there are a number of things we look at. So it's the tissue Doppler imaging, the transmitral blood flow. We look at deceleration times of the transmitral flow, and the left atrial size as well. Different associations across the world have slightly different criteria, but it's important to realize that the patient has to have more than one criteria positive before we say that diastolic dysfunction. So in this patient, we have diagnosed COVID pneumonia plus heart failure with pulmonary edema with preserved systolic function. So we have to treat both the COVID pneumonia, but we have to treat the diastolic heart failure as well. And clearly this patient, if you didn't pick up that there was a significant cardiac pathology, then we would be treating the wrong thing as well if we were only treating the COVID. Okay, and finally, a young obese diabetic male, and certainly our experience has been that it's been the obese patients that have been doing badly amongst the COVID pneumonias that we've been seeing. Again, fever, chest pain for a few days, a little bit hypertensive, very hypoxic. He's got a positive COVID test, and he's got a really high D-dimer. Typical changes on the heart, on the X-ray, chest X-ray as well. So what do we find here? Okay, so this is apical 4-chamber view, and you can see that the atria are really large, and this is the short axis view. You can see this D-shaping of the left ventricle. Again, let's just keep that going. So really big right atrium here, big right ventricle. See this, the interatrial septum bowing. Here we see the interventricular septum bowing into the right ventricle. Now, right ventricular enlargement is useful for us to know because it's one of the poor prognostic signs in patients with COVID. And although it's pretty hard to do anything about that, it's useful for us to know this, firstly, because we know that it's poor prognostic, and that can help us to decide on whether patients are appropriate for further care or not. But also it does give us a guide about how we must treat these patients. We need to be a bit more active with diuresis. We need to ensure that the patients aren't hypoxic because hypoxic lungs cause these high pressures. So it does guide how aggressive we need to be in our therapy. But most importantly, it's been useful to see that this is a prognostic sign. So again, always look at the right ventricle in COVID patients because it can be helpful from that point of view. And this was the patient, poor prognostic features, and in this patient, the patient was triaged to palliative care and died fairly soon. And then just finally, you can find this on PoCUS101.com. This is quite a nice thing to go through to have a look at how echo can be helpful in COVID. And essentially, we always need to think that we don't have to ultrasound everyone, despite the fact that we're keen. But if they do have cardiac symptoms, then we should look at the cardiac ultrasound, and then this can then give us these things that we've seen, which can guide our treatment and can certainly make our life a lot easier. So if you need to get this PoCUS101.com, I think it's a fairly nice thing to guide us. Vidya, that's me.
Thank you, Prof. Very interesting indeed. So it seems like we don't really need any new fancy ultrasound software for COVID-19 echo. We just use our standard echo skills that we already have, but we extrapolate them now to the COVID-19 situation. That's absolutely great. I see that we have 1 minute before Sean goes. So let's maybe ask Dave Clutie if you can unmute yourself, and if you want to put your video on, you're welcome, and ask Prof your question regarding McConnell's sign.
Cool, thanks very much, Vidya. Thanks for that, Prof, and to the guys there doing EMSSA. Just a quick question I wanted to ask, please, and apologies, my video is not working for the Wi-Fi, but I know you mentioned that McConnell's sign is quite useful when trying to differentiate other causes of pulmonary hypertension, I guess, or right ventricular strain, specifically for right ventricular MI and a PE. But I'll be honest, I always thought it was just for a PE. I wasn't aware that it was also for right ventricular MI, and I was trying to work out how would you attempt to use that, especially if you've got someone who can't really give you an accurate history, and when your Wells and Perk rule, like you mentioned, aren't really applicable during the COVID pandemic.
Yeah, and that's many people aren't aware, and they think that it is pathognomonic for PE, and it's not. So you're absolutely right, and that's where point of care ultrasound is great, because you do incorporate all the other things. And so obviously ultrasound findings, ECG findings, clinical history, and so on are all going to be important. But it can be really difficult because your troponins can be up for both these. We expect with right ventricular infarct, though, it's unusual to have isolated right ventricular infarct, so you expect to have inferior infarct as well.
Yeah.
And obviously the ECG and echo features of that. But it's always worth just thinking, could this be something else other than the PE? And obviously right ventricular infarct, you wouldn't expect the degree of hypoxia and so on that you might get with that. But yeah, it's a good question. And the main thing is just to be aware that there are other causes as well.
Rob, just while I've got you, if you don't mind, if I could ask another question on the kind of the same topic. We see quite a lot of guys who, doing the ECGs and they're kind of they're on the ventilator, etc., and they haven't exactly decompensated. But we do an ECG, and you find these guys have got features of a right axis, not really many other features of, say, a classic PE, but they look like they've got features of kind of acute right heart strain. And again, could that just be the COVID pneumonia giving you such severe hypoxic vasoconstriction and a cor pulmonale-like picture?
Absolutely.
It's quite a difficult one to do as well.
Yeah. No, so right axis doesn't tell you anything about what the cause. It just tells you that the right side is taking strain. And absolutely, that can be an obstruction in the vessels, like a PE, but it also could be hypoxic vasoconstriction. So all the ECG findings with acute right-sided things are very non-specific and often not helpful at all. You might just get the right axis with tachycardia, and it could be any of those conditions, except the infarcts. The infarcts, we do tend to see the more characteristic findings.
Okay, thank you very much.
So we're moving along. I see there is a question from Dr. Pele, but we're going to get to it at the end of the talk, if you don't mind, Polosho. So as healthcare providers, we are often faced with very unstable, hypoxic COVID patients or persons under investigation who we end up needing to intubate. And Sean is now the expert on this. So we cannot stress enough the importance of wearing appropriate PPE and ideally intubating in a negative pressure room. Aerosol generation is a big concern. So as teachers of COVID intubation, we advocate using a video laryngoscope so that your face is physically further from that of the patient and visualizing the tube passing through the cords. We also stress that after intubation, one avoids unnecessary leaning over the airway and contamination of our stethoscopes. So Sean is now going to introduce you to the use of ultrasound for endotracheal tube conformation.
So when it comes to airway management in the COVID-19 patient, the stakes are quite high. If you have an inadvertent esophageal intubation in an already hypoxic patient, it could be deadly. But at the same time, if you do have a correctly placed endotracheal tube and then you feel like you need to remove it and sort of work with the airway again, it could increase your contamination for all those involved. Vidya, we don't have any continuous waveform capnography available at the moment in our unit. I'm not too sure if it's available in most places. Do you guys work with it regularly?
You know, Sean, sometimes we have it, sometimes we don't. It's usually the weak link is that little connector that attaches to the monitor that we often find ourselves without. So more often than not, I would say we go without end-tidal CO2. How about you guys in the Eastern Cape?
Yeah, so similar. That little connector is a bit of a problem to get via the supply chain sometimes. We also struggling a bit with auscultation because you know you have your already contaminated hands and now you want to take your stethoscope and put it up to your face, which could result in increased risk to the healthcare provider.
Yeah. So the question then is actually, how can ultrasound help us?
So we started wondering sort of similar things as well when we were looking at COVID-19, looking at our simulations and trying to figure out how we could confirm endotracheal tube placement using other creative means. There's two commonly described techniques that seem to be out there. So one is real-time tracheal ultrasound and use of the lung sliding sign.
Okay, so if you have those two options, which one is going to be the best and the safest in this current pandemic?
Real-time tracheal ultrasound, shown here, is a great technique with some evidence supporting it. Essentially what you do is take your high-frequency probe, place it over the lower trachea, just above the sternal notch. And as you'll see towards the left of the screen, you'll see an air-filled space. It's best used in real time, so actually as you're passing your endotracheal tube, and if you then see a second air-filled space appearing, that would suggest that your endotracheal tube is actually in the esophagus. I'm not going to go into too much further detail about this. It's not a commonly taught technique in South Africa. It's not part of our level 1 teaching. And one of the concerns with it is it also actually requires the unit being at the bedside during an aerosol generating procedure, which is maybe not always the best, as I'll share later. Use of the lung sliding sign, on the other hand, it's actually got a better positive predictive value and a higher specificity in some studies than the real-time tracheal ultrasound. And it has the other additional advantage of actually being able to identify if there's been endobronchial intubation as well. what I quite like about it is I think most South African emergency doctors have got some exposure to this lung ultrasound. You don't necessarily be able to do the entire 12-point or 8-point lung ultrasound that Craig was describing earlier. But I would say that probably most of us, at least those of us that have had some level 1 training, would be able to do this quite easily. Vidya, would you say most of the doctors in your unit would be able to do this quite quickly and easily without much further training?
Well, let me say that I really hope they can, because after all the nagging and teaching, I really do hope so. But maybe, Sean, you should talk us through it.
So it's really quite a simple technique. Either after your endotracheal intubation attempt, or if you are expecting that your endotracheal tube may have become dislodged, essentially the linear ultrasound probe is placed anteriorly, somewhere between the 3rd to the 5th rib spaces. If you are seeing lung sliding bilaterally, as on this video, this can help you to confirm endotracheal tube placement. If you only see it on the one side, consider that you may have pushed the tube down too deep and consider withdrawing the endotracheal tube.
Okay, but what about pneumothorax? How can you tell the difference between a pneumothorax and an endobronchial intubation on ultrasound, especially considering that there's no lung sliding with either one when you ventilate the patient?
So this is an example of what you might see if a lung is not being ventilated. It's called the lung pulse, or a cardiac impulse that's being transferred all the way up to your pleura. So you can see there's almost sliding that seems to be pulsatile. You can even see a comet tail or two, but there's no sliding that's taking place with ventilation. If you were to actually have a look with the M-mode on the next one, you can actually see there is a pulse that's actually, you can actually see that your pulse here will actually correspond with your monitor as well. If you are then bagging the patient, you won't see any lung sliding with the ventilation itself.
Okay, so that's a sign of endobronchial intubation then.
Well, yeah, as you said, a sign that that lung is not being ventilated for whatever reason.
Correct. Okay. An excellent tip that I like to teach is that if you just generally are practicing ultrasound on your patient, if you ask them to hold their breath, you can actually generate this image, and then you can get an idea how the lung pulse actually looks.
So yeah, thanks for that. That's a good way to practice as well. Just moving on to infection control, I think one of the biggest realities of this situation is that in most of our emergency departments, we're not seeing necessarily confirmed COVID positive patients or negative patients. We're seeing a lot of persons under investigation. We really, really do owe it to our patients to be able to try and protect them from contracting this highly infectious virus while in our units.
I agree completely. It doesn't help using our wonderful ultrasound machine, going from patient to patient, and spreading the disease, So, Sean, tell me, what are some of the strategies that you've been using to prevent your machine from actually becoming an incubation station for COVID?
So for us, it's been taking quite a lot more planning than usual. Your infection control actually starts when your shift starts, to be honest. We've taken to doing a few things. We're quite lucky in our unit to actually have 2 ultrasound machines, which is amazing. We have dedicated one to our respiratory side and one to our non-respiratory side. We cover our ultrasound machine dials with plastic, and as you can see, this plastic's kind of loose there at the bottom, so you can still manipulate your dials quite easily through them. When it comes to actually doing the ultrasound, I think Craig summed it up beautifully when he said earlier, you've got to think about why you are doing the ultrasound, or potentially why you would not be doing the ultrasound. You want to know who's going to be doing your ultrasound scan. Ideally, although we all want to learn ultrasound and we do want to train and to practice, it's probably not the best time to be doing a training scan on a confirmed COVID positive patient, as you want to limit some of the time in the unit. And you want to think about what views you're actually looking for, which probe you're going to use. I like to enter the patient details already into the machine before I go into the room so that I can save some images. And you want to remove anything that's not necessary from your ultrasound machine, as well as making sure you do have what is necessary. So if you need gel, paper towels, that you take that all in with you as well.
Yeah, I completely agree. I think the less time we spend next to the patient, the less risk of infection to the healthcare workers.
When you're actually with the patient, there's a few ways that you can protect your machine from contamination and protect the next patient you're going to be scanning. One way is, as we mentioned earlier, you don't want to have your ultrasound machine close by if you are doing aerosol generating procedures. So think about that, think about why you're doing it, and maybe make sure that your machine only comes in and leaves as you go. You can actually keep a bit of distance as well. So in this slide, you can see we've moved the ultrasound machine quite a distance away from the patient so that if it is an awake patient, they don't reach out and grab it. You can also try and keep one sort of potentially clean hand. So maybe keep your left hand to just work with your dials, maybe put a bit of practice squeezing your gel with your left hand onto the probe and keeping it clean. And finally, when you are fully donned in PPE and it's difficult to see what's going on the screen, think about actually saving some videos and saving some images there as well. Vidya, do you have anything that you can add to the sort of before and during to prevent contamination of your ultrasound machine?
Yeah, I think when it comes to before, what we usually are faced with is the situation where we're using our ultrasound machine in our tents outside the hospital, so our people under investigation tents. And so often the problem there is finding plug points to actually plug your ultrasound machine in, because there's, you know, maybe an extension cord running by and it's either the ultrasound machine or, you know, the infusion set that's going to take that plug point. So a good tip that I'd like to recommend is that you keep your machine charged while it's not in use, so that when you get into the tents, you're using your battery life, and hopefully that's going to be good enough for your entire examination. The during, you know, I've taken to using one of those scuba masks. I actually have it here if you guys want to see. It comes with you put a ventilator filter on top, so it comes with a special connection. And the reason I like this, although I look a little like Darth Vader in there, I like it because it doesn't fog up. So, you know, the goggles often fog up and you can't really see properly. And it's very frustrating when you're working with these patients and looking at the ultrasound machine. And these scuba masks are very good for the anti-fogging ability. So I like that. It does get a bit heavy on your head after a while. So it's perfect for just doing the scan and getting out.
Oh, that's awesome. Okay, I'm going to have to try and get myself one of those as well. When you're done with your actual ultrasound, one of the most important parts is afterwards as well. And how do you actually decontaminate your machine? And I had so many questions about this. We spoke to our manufacturers, we've spoken to other manufacturers, looked it up everywhere we could for sort of sources on the internet. And I'd really recommend to everyone, before you even start, that you chat to the manufacturers of your ultrasound machine and see how they would recommend sort of decontaminating it. For me personally, I move the ultrasound machine away from my patient to where I'll be cleaning it. I doff as I would normally, then re-don clean gloves, make sure we've wiped off all the gel, all of the blood, everything like that. Remove any probe covers if you are using them. And then you can essentially do what's called a low-level disinfection. Now, we know that COVID-19 or coronavirus is killed by soap and water. We know that it's killed by at least 70% alcohol, and we know that it's killed by at least a sort of a 0.5 solution. Our manufacturers reckon that you can sort of wipe down most of your machine with any one of those three. They, as most manufacturers, do recommend that you don't get water anywhere near your dials, and so our plastic cover helps a lot with this when we're trying to clean it afterwards. Some manufacturers would say you can use free-flowing water, sort of soap and water on your probes itself, and I have definitely done this before with other ultrasound machines in the past. However, I've also worked in resource-limited settings where you have the same ultrasound machine for, 5 to 10 years, and those probes do get damaged with time. And it's maybe not the best idea to go dunking those sort of damaged probes into water or having free-flowing water go over them. So generally, your safest is going to be wiping down your probes with soap and water, not letting free-flowing water run over them. Our manufacturers reckon bleach is safe on the probes. Other manufacturers reckon that alcohol is safe on the probe so long as you wash it, so long as you wipe it off with water again immediately. In general, find out what works for you and what's the most practical. just think a little bit about where you've touched with your contaminated hands and where your patient might have reached out and grabbed onto the machine as well. So things like the plug, our battery life is not as good as yours, Vidya. We need to plug ours in pretty much the whole time. So make sure you've wiped down your plug and the gel bottle. You can wait the recommended amount of time for the decontamination to take place, and then you're ready for your next patient. Vidya, anything else you'd like to add onto this? What do you guys do to decontaminate?
Yeah, we do it pretty much the same way. I think I want to re-emphasize what you said. Absolutely correct that you shouldn't be putting alcohol on the probe itself, because you know those piezoelectric crystals are quite sensitive, and putting alcohol on the actual probe is going to damage your probe in the long run. So I agree with that, and we do it pretty much the same way. Wipe down all the obvious gel, and then afterwards we use a biocide solution. It's a little sachet that we dilute in 10 liters of water. Wipe it down with that. So I think all of those things that you've mentioned, we're doing exactly that. The other thing I could maybe mention is some machines, especially those touch screen ones, if you're lucky enough to have, they have a cleaning mode where you can just put it onto the cleaning mode and then wipe down everything. So while you're cleaning, you don't activate any of the touch screen. So it's worthwhile just checking if your machine has that option, because that's quite useful.
Great.
So yeah, so to summarize then, Sean, you know, you've covered intubating, confirming your tube with ultrasound. You've summarized the disinfection, and you make it all sound so very easy. Let's have a look at the chat and see if there's any questions for us. Okay, I see that Polosho has a question, and that is for Craig. Polosho, you can unmute your mic, and you can put your video on if you like as well, and you can ask your question for Craig.
Sorry, I'm still in the unit, so they usually don't allow videos. Do you mind I just speak through the
That's fine.
Yes, ma'am. So the question is basically, like, I wanted, like, do you necessarily have to have all the lung findings to suspect a COVID, like all the subpleural consolidation, the irregular pleural thickening with the B lines as well, or like those subpleural consolidation, are they specific for the COVID? Do they look a particular way? Because I've also read that you can also get some type of subpleural consolidation with either PE or pneumonia. Like, do I use my clinical history, exam and stuff, and then suspect, like in terms of clinical suspicion of COVID, or those type of subpleural consolidation give me a clue that no, these ones, they look like the COVID ones?
You're absolutely right. Like anything with point of care ultrasound, you need to take it in the clinical context of your patient. And that's why you need to have exam taken the history, and then use the ultrasound to help you to what you think is going on. And like I've said, unfortunately, there is no pathognomic feature specific for COVID. I mean, they've only just come now with Valpicelli and his crew on this light beam artifact, which is debatable whether that's specific for COVID. Subpleural consolidations definitely are not specific for COVID, nor are they for PE. They definitely do occur in PEs, not as commonly as we think though, but they certainly can occur. And like you said, it's a combination of features, and you'll typically a PE, you wouldn't find as diffuse subpleural consolidations, and that you wouldn't have as diffuse B lines and the pleural irregularities that you would see in a COVID pneumonia. So yeah, you've got to take it in the context of your patient and put it all together and come to an overall idea.
I can chip in there as well, okay?
Yeah.
Important thing to remember is if you see B lines are the most non-specific thing. So that can be pulmonary edema, it can be pneumonia, it can be viral things. Where it starts getting helpful is when you start seeing the pleural changes and you start seeing subpleural changes.
Absolutely.
So for example, a patient with heart failure will have normal pleura.
Yeah.
So that's useful. And if you get really experienced, so I think I might be able to tell the difference between, for example, influenza pneumonia and COVID pneumonia. But I'm willing to bet that if we actually put that to the test, I'd be wrong. But it does, so, you know, so if you get subpleural changes, that's not heart failure, that's not pneumonia, that's then a viral thing. So you can, it is helpful, but you still have to maintain the knowledge of what actually causes various things and what you can exclude and what you can't exclude from the various findings.
Yeah. What the our Chinese colleagues did was that they looked at color as well over those areas of subpleural consolidation. But that was also debatable whether that actually occurred. So they thought that in a PE setting, subpleural consolidations would be obviously reduced color flow. But they actually found, and then in pneumonia, general pneumonia, you'd have an increased color flow to that area. But what they actually found in the COVID pneumonia, that there was also a decreased flow to those areas of subpleural consolidation, and potentially looking at the pathology of a clotting abnormality potentially. But as yet or not.
Okay.
So if you see subpleural consolidations, the first thing you should think of should not be pulmonary embolism.
Absolutely not. No.
The most common finding on lung ultrasound for PE is nothing. It's normal. And those small, fine peripheral things, that's very rare, very, very rare.
It is rare. And the reason is because the blood supply for the periphery of our parenchyma, our lung parenchyma, is not pulmonary, it's bronchial blood flow. So we very rarely do you get subpleural consolidations with a PE. Yeah.
And then because I joined in a bit late, with the B lines that keep disappearing with respiration, is there a specific name for that? Because I know
that was that one description of the light beam artifact, which they've just recently described, and it's thought to occur in the early stages of a COVID pneumonia, and represents the ground glass appearance that occurs on CT.
Okay, thank you very much.
Cool.
Thanks, guys. I see that there are no more questions. So I assume that everybody else is completely happy or completely lost the plot, either way. Guys, we have come to the end of our session, so I hope that you have all learned something worthwhile to take home with you. I would like to end off by thanking each and every one of you for joining us today. You know, there can be no teaching without learners. And of course, I want to thank our expert panel, Prof. Wells, Craig, Sean. Thank you for your time and your expertise. I know that, you know, dragging you away from your units at this time is not an easy ask, but you've made time for us and you've put your talks together. So thank you from the bottom of our hearts on behalf of the audience and myself. And then, of course, our behind the scenes guy, Jed, thank you for your time as well. Jed, as I mentioned earlier, has recorded the session. So he will upload it to YouTube and the link will be made available on the EMSSA website, as well as, you know, we'll distribute it via our usual social media platforms. So that is it. Stay safe, everyone, and goodbye.